All right, folks. So folks are slowly trickling in from the waiting room. So I'm going to do yet another round of awkwardly prolonging this one sentence as long as I can before we officially start the housekeeping and the introductions and then the actual session. Last session of day 3 of our fifth annual Overdose Awareness Series. So thank you for tuning in. All right, cool. We have a solid 40 plus folks in, so I will now officially start. Welcome, everyone. I'm assuming no one's tuning in for the first time today, but if you are, my name is Alex Sorotsky. I'm one of the educators with the Washington Poison Center. And we are about to start the final session. So a little bit of housekeeping before I pass it on to our guest speaker today. As always, please ask your questions in the Q&A box, post comments, share experiences, share resources in the chat box. If you've got a tech issue, put that in the chat box. We will address questions as we can. And yes, you will get a certificate of attendance for the day, providing you fill out the survey we will send once again when this session is done. So it is my pleasure to introduce our speaker, Dr. Colleen Cowdery. So she is a current medical toxicology fellow at the Oregon Poison Center, an emergency medicine physician at Oregon Health and Science University. Dr. Cowdery's interests include emergency trends in severe and fatal overdoses. So thank you so much, Dr. Cowdery, for joining. And let's get your slides pulled up and then we'll pass it on to you.
Absolutely. Give me just a minute to get these shared. And let me know if uh, things are sharing correctly. I think you're seeing my
Yep.
notes right now. Are you
Now
seeing my
we're
notes still?
not anymore. It's good full screen
Great.
now. Take it
Okay.
away.
Wonderful. There's always that first little section of getting things up. So I'm Colleen Cowdery. Thank you so much for having me here to talk with you guys. We will be talking about adolescent over-the-counter medication overdoses. So I would just wanted to start this talk off by saying, please interrupt at any time, put your questions in the chat, and I'll just kind of answer them as we go. There also will be time at the end for more questions. I'm going to keep this relatively brief, so be plenty of time for discussion at the end, and we may end a little bit early, which I figure as the last talk of the day is perhaps not the most unwelcome. One thing I did want to address before we start this talk is for adolescent overdoses, if we look at them from the 1,000-foot view, undeniably the biggest cause of mortality, just like with unfortunately everything in poisoning right now, is undeniably illicit fentanyl. Uh, we're not going to talk about that at all. I think we've got multiple people today talking about illicit fentanyl today and throughout these sessions. I'm just going to be sticking with over-the-counter medications. So, our learning objectives. First things first, we're going to talk some about just the risk factors for adolescent overdoses. We're going to look at some of the most common over-the-counter medications that are involved in suicidal ingestions, in substance misuse and abuse, and in clinically significant therapeutic dosing errors. I'm also going to very briefly talk about what those terms mean to me when I'm using them, since I know that abuse of substances is kind of, in some ways, a fraught term, and different areas use that term differently. And then we will finish up talking with some implementable strategies and what we can do to kind of decrease the overall risk of adolescent overdoses and the degree of severity within the overdoses that unfortunately do occur. So, some definitions first. Suicidal ingestions are sort of what they sound like. It is an intentional ingestion of substance with intent to harm or have a self-destructive purpose. Misuse is any intentional ingestion of substance for a reason other than self-harm, but a use that is inappropriate or incorrect. Abuse is kind of a subheading of that, where the specific improper use is for a recreational purpose, for euphoria or a psychotropic effect. And then a therapeutic error is any use of a substance that deviates from the therapeutic regimen unintentionally. So, an example of misuse might be someone taking extra doses of Benadryl because they want to get to sleep. And abuse might be someone taking extra doses of Benadryl because they're trying to get high. These are the definitions that are used by the National Poison Data System, which is why they're the definitions that I'm using. I know that they won't necessarily line up with the definitions that are used by all agencies or areas, but they're the most common definitions you'll see with most publications in the area of toxicology. So moving on, why do we want to talk about over-the-counter overdoses for adolescents specifically? So unfortunately, the incidence of adolescent overdoses is increasing, and unfortunately, the incidence of mortality is increasing with that. Um, this graph is, if you look on the left side there, it is a log scale. So both the male and female ingestions are increasing. The mortality is increasing, and much more dramatically for the female than the male. Historically, uh, female suicide by poisoning in adolescence has been lower than males, and unfortunately, that may no longer be the case. This graph is specifically with mortality rates, but it is unfortunately a trend that we also see with overall exposures for suicidal ingestions and also for abuse. If you look at specifically misuse, adolescents are the fastest growing population for that. So this is a growing issue, and it has been growing for a number of years. And unfortunately, I expect that in the near future, it will continue to grow. So it's definitely something that is worth our attention. It's worth separating out adolescents from younger children and from adults because the behaviors we look at are different. Um, it is worth knowing that, adolescents, their data tends to be grouped with pediatrics because they're under 18. But the reasons why a 14-year-old takes too much of a medication are going to be very different from the reasons that a 4-year-old has taken too much medication. Therapeutic dosing errors are much more likely to be self-directed. And, thankfully, there's not a lot of 6-year-olds out there who are intentionally taking too much of a medication to get high. So, very different strategies and thoughts behind behaviors. If we look here at the distribution of reported reasons for exposures and fatalities by age group, you can see, as we would expect, under 5 years old, it's unintentional. And greater than 20 years old, it's intentional. And for the ages in between, we see a transition. And by the time you get to teens, the vast majority of fatalities come from intentional ingestions. I think it's worth noting here, unfortunately, we are seeing the beginning of a transition for the 10 to 12 year age group. Historically, it was very, very rare to see intentional suicidal behavior in children younger than age 13. And we are now, I think, seeing a growing number of younger children who are exhibiting intentional misuse and intentional suicidal ingestions. And for patients who are that young and who are feeling suicidal, um, medications represent an accessible method where other methods may be a little bit harder for them to access. Uh, Over-the-counter medications are important for us to think about specifically because they are what is accessible and common. Um, this is true for all age groups. People will first reach for what is in front of them, and over-the-counter medications are nothing if not accessible. When we think about suicidal ingestions, thankfully, as a population, adolescents are a very healthy group. So there's not a lot of, 15-year-olds who are on multiple medications for their blood pressure and their heart. Um, Adult overdoses from cardiac medication can be very, very dangerous, but we see a lot fewer of those in teenagers just because teenagers aren't on heart meds. But unlike a 6-year-old, a teenager can walk into any CVS and buy a bottle of Tylenol, and their parent doesn't need to hold their hand, and a cashier is not going to stop them from buying it. So teens can access Tylenol, ibuprofen, aspirin, Benadryl, and there's pretty much no barrier there. When we think about misuse and abuse of substances, adolescence is the age where that begins. Like I said, not a lot of 4-year-olds, uh, but this is the age group where people are beginning to explore behaviors like that. And when we think about therapeutic errors, this is the age where teens begin to self-dispense their own medications at home. And many teens are not taught specifically how to do that. They may not have the knowledge of which medications should be taken for what purpose. They might not really understand how to dose a medication or why it's important to understand dosing and what might happen if they do it wrong. I had a patient who was, I think, around 12 or 13 who had a headache at her grandma's house. So she just picked up a pill bottle and took a couple of them for her headache. And she didn't even think to wonder what kind of medication she was taking. And it was, unfortunately, her grandmother's heart medication. So, you know, again, adolescents have behaviors that aren't necessarily what you might expect from either adults or young children. They have the beginnings of adult behaviors, but they may not always have a fully intact thought process with, understanding of consequences. And that is developmentally appropriate for their age. So, some adolescent risk factors that we should be aware of. Many of these will be very similar to risk factors in adults. The biggest one for particularly suicidal ingestions, but also abuse and misuse of substances, is mental health. Um, Obviously, mood disorders, depression, anxiety, things like that will have a massive effect, and multiple studies have found a very strong correlation between the presence of mood disorders and other mental health concerns and incidents of overdose. But for adolescents, it is also very important that we remember that you don't need a prior history of any kind of mental health history for an overdose to occur. It is developmentally appropriate for adolescents to be extremely impulsive, and a significant number of teens, unfortunately, may overdose on a medication just because they had the thought to do so. Maybe something very stressful happened at school, and maybe their first boyfriend or girlfriend broke up with them, and it is the worst thing that has ever happened in their life, as a true statement. And that level of impulsivity leads them to make decisions that they may regret immediately afterwards and may or may not be related to any, diagnosable depression or anxiety. But these kinds of impulsive acts should be taken into account. Another significant risk factor, anything in the family history as far as substance use and misuse in the home, any history of family overdose, intentional or unintentional, and a lack of parental supervision. And this isn't just affecting the adolescent's risk for abuse, misuse, and suicidal ingestions. Poor parental supervision will also increase the chances of a therapeutic error. And I think perhaps the risk factor that gets the most attention in the media is peer group behaviors and social pressure. This is also a risk factor that I think a lot of parents feel very powerless over. And in some ways, it is very difficult to impact, but it also is a potential very protective factor. And it is something that people can try to, approach their teen about as a way of, you know, teaching teens that they can be a positive social pressure for their friends to try to decrease risky behavior in their friend group. Uh, as I mentioned earlier, historically, male adolescents did have a higher overall incidence of exposures and incidence of severe and fatal overdoses. But recently, this has maybe been a little bit less true, and we may, for better or worse, be achieving gender parity in overdose. I'm not quite sure what to make of that, if that's a good thing or not. Um, I think this is not something that, I am an expert in. I'm not a child psychiatrist, and so I can't really speak to the underlying risk factors and reasons for this, but we are seeing higher rates of mood disorders in adolescents now than ever before. And I suspect that is related to the growing incidence of intentional overdoses. Adolescence is always and has always been a very, very stressful stage of life, but we are seeing unprecedented levels of, clinically diagnosable mood disorders and suicidal attempts in increasingly younger children. I did want to take a moment separately to talk about challenges and social media when it comes to peer group behaviors. This is a very complicated subject that I don't think we fully understand the implications of, and it is not something I am an expert in. But I do think that there is some data we do have on it that's worth making sure that people know. I think everyone has heard of at least some of these challenges on the news, if nowhere else. Benadryl challenge, Tide Pod challenge, those, eat a tablespoon of cinnamon without water, or, eat however much nutmeg. Challenges are not new. This is not a brand new thing since the internet started. Um, I know of at least one challenge that occurred in the 1930s, the Goldfish Challenge, which was very popular on American college campuses to swallow a goldfish and regurgitate it live. Why did people want to do this? I don't know, but it was a very popular behavior. These kinds of challenges have always existed and probably always will. But one thing that is very different within the past couple decades is that now these challenges can propagate very, very quickly. They can go viral, and through social media, they can spread very, very rapidly. There have been some observational studies that have looked at the relationship between like Google searches about these topics and the number of reported exposures to the National Poison Data System about these substances like Benadryl or Tide Pods. And we have seen a extremely close temporal association. The lines that are up and down on these graphs are the peak Google search period, and looking at a couple months before and after that peak search time, we can see there is a very close temporal association with the peak use of that substance for misuse and abuse. But I think it's very interesting that this study also found that peak suicidal ingestions of those substances came a couple months later. So these challenges may be sort of popularizing the use of these substances and allowing teens to hear about them. This data is specific to adolescents. So it is possible that either just exposure through media or through their friend group and knowledge of use of these substances is increasing the odds that this substance might be picked for use in a suicidal ingestion. But there is a lag time to the peak time of that, which could be a time period that there could be intervention on the part of, public health pediatricians. Um, as for the method of intervention, I will not venture a guess on that. That is not my area of expertise. Uh, Turning now towards the actual medications themselves, what medications do we think about when we most classically think of a suicidal ingestion with an over-the-counter medication or misuse of an over-the-counter medication? When we're thinking suicidal ingestions of over-the-counter meds, by far the biggest group we worry about in terms of hospitalization and morbidity is over-the-counter analgesics. So when we say that, we're thinking acetaminophen, most common brand being Tylenol, aspirin, and nonsteroidal anti-inflammatories, NSAIDs like ibuprofen. It would be great if all medications had labels that were as clear as this, where you know exactly what is in them. That's not always the case. Uh, so of these three, acetaminophen, I think, is our biggest culprit. If I got to pick one medication over the counter that I could change the impact of, it would be acetaminophen. Uh, this, I think, of the over-the-counter analgesics probably has the largest number of adolescent exposures and morbidity and mortality from liver failure and, transplants, unfortunately, fatalities. Um, Aspirin is a little bit less common now than it was in the past. It has sort of lost some of its popularity as a home analgesic, and I think most people now think of aspirin as a heart medication more than a headache medication, which I'm not unhappy about. We still do see salicylate overdoses, and they can be extremely severe and lethal. But we see fewer very, very large salicylate overdoses today than we saw maybe 10 or 20 years ago. And then NSAID overdoses, we still see many, many, many exposures from, but happily, in comparison to acetaminophen and the salicylates, it has a much wider therapeutic window. So it's harder to eat enough ibuprofen to get a lethal overdose. Um, which is not to say it does not happen, but it's much more difficult to achieve. And so many ibuprofen overdoses have a lower severity, which is not a bad thing. Like I mentioned, it would be great if they all were as clear as this. Unfortunately, that is not the case. If anybody would like to look very closely at these boxes and tell me the difference between the top box and the bottom box, I'll be very impressed because there isn't a difference. The migraine relief Excedrin is in fact the exact same pill as the extra strength headache. They just put a different box on it for advertising reasons, I assume. But it is different in its ingredients from the tension headache. So it can be very, very challenging for all consumers, not just adolescents, to even know what the ingredients are of the boxes that they're picking up. Anybody who's from the Southeast may be familiar with Goodies powder. Uh, they come in a variety of colorful packaging and many different formulations. Some contain acetaminophen, some contain salicylates, and many people don't necessarily pay attention to which kind of goodies they're grabbing. They just think of them all as a headache medicine. Uh, Doan's, again, it's a backache medicine, but it is in fact a very large amount of salicylate, and you know, you can overdose on that pretty easily. Midol has changed their packaging where now the biggest thing on there is just the name of the medication and itself, Midol, and it's a little bit hard to find the active ingredient. And this has the biggest word on it as non-aspirin, but you kind of have to hunt a little bit to find what is on it. So the reason I have all of these pictures here is just to kind of illustrate that it is not easy to immediately determine what even is being grabbed. And very frequently in overdoses of over-the-counter analgesics, the patient might not even know what it is they overdosed on, regardless of if it was a suicidal ingestion or not. Very frequently, there are cases of somebody who says they overdosed on ibuprofen, because either that's what they think is in there, or because they call all of these ibuprofen, which I think is a excellent opportunity for potential intervention, is just education to look at active ingredients and know the difference between different analgesics. Uh, when we think of misuse, misuse is the plurality of ED visits for adolescents historically. 48% is misuse, and that includes abuse of over-the-counter medications. Following that is suicidal ingestions, and then for adolescents, a small minority is therapeutic errors. The most commonly misused or abused substances are dextromethorphan and diphenhydramine. Classically, it was dextromethorphan, which you might hear of as like robotripping, coming from the name Robitussin. It's also found in a ton of different cough and cold medicines like Coricidin cough and cold, which is sometimes referred to as triple C. It is sometimes an ingredient in purple drink or lean. And if all of this sounds a little bit dated, it's because it is. Dextromethorphan's heyday was around 2006 to 2012 when its use kind of peaked. And since then, it has been declining. And I expect it probably will continue to decline. It's, for whatever reason, kind of fallen out of favor. These days, it's all about Benadryl. Benadryl is a very, very, very commonly misused and abused substance, particularly with adolescents. And I think most likely everybody in this meeting will have heard about the Benadryl challenge. Um, Benadryl can have, uh, unwanted side effects, even at, only doubling, tripling, quadrupling the dose, as is more common if people are misusing it to try to go to sleep. Uh, but for teens who are attempting to have a recreational effect and, get high, have hallucinations, things like that, they may be taking many hundreds of milligrams, sometimes even up to multiple grams of Benadryl. And at that level, it is very dangerous and frequently leads to hospitalization for multiple days. It can lead to intubation in the ICU, and there are fatalities associated with it, unfortunately. From just my own experience talking with teens who have been hospitalized and some of them intubated following use of Benadryl recreationally, they were not always even aware that that was a possible outcome for the amounts that they were taking. And many of them had become aware of taking large amounts of Benadryl for psychotropic reasons, either through friends or through internet sites like Reddit or similar forums. And when we think about therapeutic errors in adolescents, all medications carry the risk for therapeutic error. Um, Liquid medications tend to have a slightly higher risk than capsules simply because there is the possibility of not understanding how much they are meant to pour out. Capsules tend to be pretty cut and dry in terms of, take one, take two. And over-the-counter medications, by their very nature, are designed to require minimal calculation. Uh, Generally speaking, for therapeutic errors, our biggest culprits are going to be combination medications, wherein patients are not even aware of what the active ingredients are in what they're taking, and particularly not being aware that their medication may contain a dose of acetaminophen. So there are numerous cough, cold, headache, fever, aches and pains medications that contain acetaminophen. And it is very, very easy for an adolescent to grab a couple different things out of a bathroom cabinet for their headache, for their back pain after, falling, doing something, uh, and not really realize that they are accidentally taking multiple doses of a single medication. So we've talked about the general kind of increasing trends with exposures and the increasing mortality recently in adolescents from overdoses. Talked about some of the most recent common culprits from over-the-counter medications and some of the risk factors that are feeding into the growing rates. Are there any things that we can do to decrease the rate of overdoses in adolescents? Is there anything we can do to decrease the severity of those overdoses? And the answer, happily, is yes, there are strategies that have been shown to decrease these rates. So, lockboxes and lock bags. Uh, they're not just for prescription medications. Any medications can be put into them. Personally, I think that lock bags are great for younger children, more for preventing exploratory ingestions in, say, a 4 or 5-year-old, for whom a lock on a bag is going to be sufficient to stop them from just getting into it. Uh, if you are in a home with a teen who has, for example, tried to overdose before or has intentionally abused a medication in the past, a lock box may be a little bit sturdier, as anybody with a pair of scissors can kind of just cut around the lock on a lock bag. Uh, but it is worth noting that the goal with putting your medications into a locked bag or even a locked box is not to definitively remove that medication from out of the adolescent's reach. The goal is more to just add an additional barrier to impulsive acts. Anybody who is sufficiently motivated can open these boxes. The goal is just to make it a little bit harder and to give someone an additional few minutes to think about if they actually want to do what they are trying to do, rather than just having extremely easy access. So you've placed your medications into an appropriate bag or box. Where do they go from there? Uh, I think it's very, very interesting where Americans traditionally place medications in their home because it's not the same everywhere in the world. Americans, culturally, we have bathroom medicine cabinets, and that's not something you see everywhere in the world. We place our medications in the one room of the house that reliably locks from the inside. And we don't need to do that. We can place medications somewhere else that isn't a locked room. Again, your adolescent could get into a medication in the bathroom as easily as they could in the kitchen, but the bathroom gives the opportunity for surreptitious use or for creating a barricade that is going to take a parent or a concerned, a friend or family member several minutes to get through to stop them from taking additional medications. So maybe place the bag or box in a public area of the home that there is traffic and people can see it and people can notice if it is not there. Avoid placing it in a lockable room or in a hidden area like the basement, because again, that is just offering the opportunity for surreptitious use of a medication or using of a medication when no one is able to get there to stop them. So, how do we give medications to kids and how do we teach them to give it to themselves? Younger children should always receive medication through controlled and supervised dispensing by the parent or guardian. Parents should not treat medication like candy. They shouldn't try to like sneak or hide or, have model any behaviors that would lead children to have relationships with medication that are like uh more likely to make them want to take medication. However, things like treating medication like candy is more likely to make a 6 or a 7-year-old overdose, not a 14 or a 15-year-old. 14 and 15-year-olds, obviously, at that time, they are most likely responsible enough to start to do this by themselves. So when they are, in the preteen years, parents should be teaching them how to dispense their own medication, but watching them do it and talking them through it so that it is something that they have familiarity with and they generally know how to do. As part of that, teens and children ideally should be taught how to read labels, what an active ingredient is, and, that you shouldn't take multiple medications that say the same thing on active ingredients. And you should teach children and teens about what happens if you take too much medication. Teaching someone that taking too much medication can harm them does not increase the risk that they will have an intentional overdose. And I think that this is important to tell parents because this, I think, comes up a lot in many kinds of discussions about self-harm, that people are afraid, parents are afraid to talk to their children about it because they don't want to introduce the idea. But educating children that too much medication can be harmful is protective. And parents should be told that having these conversations is not harmful to their children. Another very big strategy that is near and dear to my heart is purchase in moderation. Um, this is a 2-pack of acetaminophen that contains 2,000 capsules. That is 1 kilogram of acetaminophen. I don't think I am going to use personally a kilogram of acetaminophen over the course of my entire life. I don't think me and my family together are going to go through a kilogram of acetaminophen. Who needs to buy this? Nobody. Personally, I don't believe we should be selling it like this, but parents should be strongly encouraged to avoid buying Costco-sized medications because having a very large quantity just enables the possibility for a large overdose. You should purchase the amount of medication that you need to have in your home at one time. And when you run out, you can purchase some more. And I think this is a very, very simple idea, but it is one that should be encouraged. Now, this will not stop a teen from being able to go to CVS and buy their own. But again, this is all about providing an additional barrier and decreasing the ease of access to a very large quantity of medication that could be accessed by somebody who is feeling very impulsive, particularly if you are somebody who has a high risk family member in the house. And this, I think, is something that always comes up is just being aware of warning signs in your adolescence that they may be at risk for either substance misuse or an intentional ingestion. Um, Adults in adolescents' lives, including teachers, coaches, and physicians who come into contact with them, should be aware of signs and looking for them. This can be challenging in adolescence because changes in behaviors and mood and appetite, etc., is kind of normal for teens. Um, Part of adolescence is changing the way that you act and changes in mood. And it can be hard to determine what is normal adolescence and what is a warning sign without the benefit of hindsight. Uh, I do think that adolescents can and should be counseled, that they are a good protective factor for their friends, and that they, sometimes even more than perhaps their friends' parents, may be able to detect concerning changes, uh, and that being a good friend means talking to other adults in that friend's life if they are seeing things that are concerning to them. And finally, this is, I think, a huge strategy, but not an easy one, and not certainly one that any person can accomplish on their own, is legislative changes. Um, in 1998, the UK passed a over-the-counter analgesic legislation that limited the number of tablets that could be sold at once to 16, or 32 if you were buying it in a pharmacy. And it had to be sold in a blister packet, meaning each pill had to be removed individually and you could not simply shake them out of a bottle. In the 11 years following this legislation, there was not a decrease in the number of exposures. So the same number of people overdosed on acetaminophen and overdosed on aspirin, but there was a 43% decrease in fatalities, and there was a 61% decrease in liver transplants from acetaminophen hepatotoxicity. These are massive. I do not need to tell you how massive these are. Uh, this is wildly successful, and I think it would be a wonderful thing to have happen in the United States. I'm not a politician, and I don't really know how to start going about that, but I do think that these are very, very, very powerful tools to try to decrease the number of severe and fatal overdoses, particularly in the populations for whom over-the-counter medication is their easy access to overdoses, namely adolescents. Of note, starting this next February, Australia is enacting similar legislation where the maximum number of analgesics you can buy in a bottle is 50. And I wish them the best, and I hope that they have a similar success to the UK. So, in summary, overall, thankfully, mortality is low from over-the-counter overdoses, but the total incidence and unfortunately the mortality is increasing. There's a number of risk factors, many of which are difficult for the physician who may be peripheral in the adolescent's life to affect: overall mental health, peer group, family factors. When we think of over-the-counter analgesics, Tylenol and aspirin particularly can be very dangerous. And it can be very, very challenging to know exactly which analgesic is in a medication. And teens should be educated on how to tell what is in their medication. And diphenhydramine, or Benadryl, is currently the most popularly misused and abused over the counter, typically a relatively safe medication at its therapeutic doses, but can be very, very dangerous and potentially lethal at large doses. And we covered a number of strategies to potentially decrease adolescent overdoses, including securing medications in a locked bag, keeping them outside of a lockable room, supervising medication dispensing, educating adolescents on what it means to overdose, what can happen, and how to avoid it, not buying a kilogram of acetaminophen at once, and both observing for warning signs and talking to adolescents about warning signs for misuse and suicidality. And ideally, someday in the future, God please, we could work towards medication package regulation where perhaps we can get some systemic controls in place that could decrease the overall number of severe and fatal overdoses. And with that, I will turn it over to our moderators and see if we have any questions.
There we go. Had to find the unmute button again. Well, Dr. Cowdery, that was excellent. You did such a great job of presenting all of that. There is a question in the Q&A box, so this is referring, I believe, to the UK legislation you mentioned.
Yeah.
So first, a comment: those numbers are amazing, and I agree. My gosh,
Oh my God.
I hadn't come across that study before. That's excellent. The question is, do we know why or suspect why the number of exposures did not change?
Yeah. So I first I will say I don't know, but I do have a suspicion. Um, so I think someone in the comments may have said something about a big change in family norms and individual norms. There was in the studies that talked about these numbers, some comments about overall changes in economic states, because there's been plenty of data in the past that look at overall rates of suicide and the economic state of a country. And the paper suggested that some of the improvement could be improvement in the UK's economy. But to me, it's very interesting that the exposures didn't go down, because what that tells me is that the number of people trying to kill themselves did not decrease. But it suggests to me that the number of people who were able to consume a large enough quantity to kill themselves decreased. So people were still trying, but it takes a lot of patience to sit there and pop pills out of a blister packet. And suicide is frequently a very impulsive act. And people probably lose patience and just say, 30's enough, versus picking up a pill bottle that contains 100 and boom, you've got 100 pills. So that is my suspicion. I think overall number of people wanting to kill themselves was not affected by this legislation. This was not a mental health legislation. This simply decreased access to large quantities of pills.
Thank you for weighing in on that more. And to me, I'm still like just kind of like reeling from that stat
It's
that like,
huge. It's
and
huge.
to your point, it was not mental health
No,
legislation, and it absolutely affected mental health outcomes, and like that's
absolutely.
so powerful to me.
Yeah,
Makes
they
my
had
please.
Yeah, they had an initial study that came out, I think, just maybe 5 or 6 years after the legislation, that had a 22% decrease in fatalities and maybe a 30% decrease in liver transplants. And then they went back and looked at it again 11 years out, and those numbers had continued to increase. I cannot account for the increase in decrease, if that makes sense, between 6 years and 11 years. But really, really stunning numbers.
Yeah, absolutely. Well, folks, we still have time, so ask other questions as you have them. Now, I have been putting together some questions with my fellow Washington educators here. So we'll just kind of go through that list as folks are thinking of additional ones. So, from a poison center perspective, are there other age groups where we see higher levels of self-poison, like with adolescents, like you're saying?
How do you mean? I'm sorry.
Oh no problem. I'm just wondering
Mhm,
if like, so I'm often asked
mhm,
about uh or when I am giving a presentation
mhm.
on cannabis, for example, a
Sure,
lot of the times I think folks are assuming almost all of our adolescent calls are those abuse calls, folks trying to
sure.
get high. And so I try to correct and say actually most of them are those self-harm cases. And I'm just wondering,
Yes.
with Oregon Poison Center or
Mhm.
National Poison Center data, are there other age groups where we see
I
those high levels
see.
of self-poison?
So I think that if you look at um, the much older folks, there's obviously a lot of therapeutic errors coming from, perhaps some cognitive decline, perhaps some visual issues with reading instructions and seeing which bottle they're picking up. But we also do see an uptick in suicidality. Um, And they also, unfortunately, unlike teens, people who are 80 years old tend to have many health issues and be prescribed many prescription medications. So the suicide attempts by older folks tend to lean much more towards cardioactive medications, which can provide unfortunately, a much more lethal overdose. So that's something that I always keep in mind for our geriatric population. Very young patients, happily under the age of 10, very, very rarely suicidal, very, very much leaning heavily towards unintentional and exploratory ingestions. And then I'm not strictly familiar. Yeah, I can't really make a statement as far as like the 20 to 50 or 60 age group in terms of suicidal ingestions versus abuse, but my take in terms of the number of calls that I particularly am involved in, I think we do see a fair number of suicidal ingestions. And certainly when you weed out the calls and the exposures that are like no effect or very, minor effect, and we start looking at the severe effect and fatality cases, those weigh extremely heavily towards intentional suicidal gestures in all age groups. There are far, far fewer fatalities that come from unintentional ingestions.
Thank you for answering that. All right, I see. Actually, another question from Dr. Scott Phillips. So this is the medical director of the Washington Poison Center. What over-the-counter events do you see in older patients?
Mm. So older patients for over-the-counter things, we do see a lot of the same stuff in terms of if we're looking at suicidal gestures, analgesics are still very, very popular. Acetaminophen, salicylates, NSAIDs. Far fewer intentional Benadryl recreational events, though there is a shocking number of older Americans and just middle-aged Americans who misuse diphenhydramine on a daily basis as a sleep aid. And I have had a number of calls from concerned primary care doctors for patients who take truly shocking amounts of Benadryl on a daily basis that they have developed a tolerance to. So they are not using it recreationally, they're just using it to get to sleep at night, and sometimes are using more than 100 or even 200 milligrams a night just to sleep, which is pretty stunning. Um, and then past that, a lot of the over-the-counter stuff that I've seen with geriatric patients tends to be of lower clinical significance than the analgesics and sometimes the antihistamines. So things like, sleep aids and supplements tend to be a little bit safer. Sometimes they do run into issues with supplements that contain iron, just as, not realizing that taking a great deal of iron can be dangerous.
Gotcha. All right, thank you. Thank you for walking through that. And great question, Dr. Phillips. All right, so you had mentioned you showed some data on self-poisonings in males versus females.
Yeah.
And I know that poison center databases can't as easily identify non-binary patients and trans
Yeah.
patients just with the
Yeah.
way our coding is set up right now.
Yeah.
I'm wondering just if you have any data on these kind of cases, these self-poisonings with non-binary and trans patients, specifically adolescents.
Yeah, that is a phenomenal question, and I don't have the data, and I wish that I did. So, like you said, if you look back at the historical data, it is not data we were collecting. And so a lot of the older groups of data that we can look through just don't have anything for it at all. I can say just from, personal experience that adolescents who do identify as trans or non-binary or genderqueer, um, unfortunately, in our current society, they do have higher rates of mood disorders. Of It's stressful to be a teen at all, let alone being a teen in a country that sometimes has a very antagonistic cultural view towards your existence. So I would absolutely love to have more data on that. I know that the National Poison Data System does not necessarily code well for that. I know Toxicol, which is a data set used by toxicologists, does now encode for that. And so I think that moving forward for toxicologists, that's going to be a really useful data set that we can hopefully use to get some more specific answers on that, because I do think that that is a population that deserves to get some answers in terms of what their biggest risks are and what we can do to try and decrease particularly suicidal gestures in that population.
Absolutely. Thank you for walking us through that. Now, on one of your earlier graphs, when you were showing mortality rates, it looked like there was a pretty
Yeah.
big spike around 2014. And I'm
Yeah.
wondering if you know, we as poison centers or you personally have theories about what was happening around that time that might be causing that.
Let's see. I'm going to see if I can get back to.
Yeah,
There's probably an easier way to do this, but I don't know what it is. So
nothing wrong with the rapid fire slide
we're
slide
gonna just
shift.
click back through. Oop, now let's see. There, that was specific to the challenges. I think you were going a little further back than that.
I unfortunately chose a graph that was very early on.
Let's see. I think were we looking here?
Yeah, I believe so. Yeah.
Yes. So I think that this is a really great question. I if you look at like adult suicide rates, you'll see like, you can sometimes get some interesting correlations to things like economic states and like the crash in 2008 and, recessions, things like that. Uh, Adolescents are a little bit insulated from that in that they're, perhaps a little bit less likely to be looking at, oh, my retirement savings just got wiped out. Uh, so 2014, I'm not entirely certain what may have happened there. And honestly, as far as the change in the female poisonings, I would say around 2011 seems like it is closer to the time that that began to have that really dramatic upsweep. I'm not sure what would have caused that, particularly not specifically in the female sort of subpopulation. And if anybody has any thoughts on that, I would be fascinated to hear them because I do think that's very, very interesting. I do know that there have been some papers that looked at um, pediatric overdoses, intentional overdoses around the time of the pandemic. And I can't remember off the top of my head exactly what age group that looked at, but since it was looking at intentional overdoses, I have to assume pediatric intentional overdose is going to be mostly an adolescent population. And they did find that there was an initial decrease in the beginning of the pandemic, and then following that, an increase back up to and then above the level expected based on the trend preceding that, which I think at the time that study's conclusion was that that may have been from an initial kind of feeling of like closeness and togetherness and sort of, coming together in the face of the initial pandemic, followed by just the kind of the grind of quarantine and isolation and not being able to access social spaces and friends, causing that return, unfortunately, of suicidality.
Yeah, absolutely. Thank you for
Mhm.
taking on that question. That was a fairly unfair question of like, please account for all societal factors. So thank you for that. All right, there's one more question. Oh, I just lost my chat box. Here we go, in the chat box. Is there an alternative to acetaminophen that's less harmful? And they go on to say that for many Hispanic families, this is their kind of go-to cure-all for all pains.
Yes, yeah. I've always found it very interesting that families and communities, I've noticed they tend to have a medication. Like certain families, like that's an ibuprofen household people in that household take ibuprofen, or this is a Tylenol household. So personally, I'm happy that we've moved away from aspirin as a headache medication. I think that we've got better options. I do think that ibuprofen overall has a better profile in terms of overdose, in that it is harder to get to that really lethal level with ibuprofen than it is with acetaminophen. Um, so, I mean, if you've got somebody in the household for whom you're a little bit concerned about overdose, ibuprofen may be a little bit safer than acetaminophen. But if you have someone in the household that you're, more concerned with, I would say lock boxes and, minimizing the number of pills at all is probably also very, very, very valuable.
Absolutely. Thank you. Now we're basically at time, but I do want to ask one final question before we wrap up your session and move on to closing remarks. Is there a single action step you'd like viewers watching this to take? And I know you outlined a few in your
Mm-hmm.
slides there.
In a perfect world, I would love for there to be somebody in Congress, in National Congress, who would be willing to take on ownership of legislation to try to change packaging regulations. If there was a person like that, my step would be call your representatives, get behind this person, try to support this legislation. Like I said, I'm not a politician, and I really don't even know how to begin on that one. In terms of what I think public health and sort of medical personnel can do professionally, I think encouraging families for whom we know there are high risk teens about things like lock boxes and minimizing the amount of medications in a house is very useful. I know a growing number of hospitals have programs to provide lock bags and lock boxes to patients who have been admitted for an intentional overdose. Um, and I think that that is pretty valuable. And then just education of parents of preteens about things they can do around their home and conversations they can have with their teen to try to decrease therapeutic errors and misuse and large suicidal ingestions in the home.
Wow. Yeah, thank you. Very, very excellent action steps. All right, folks. Thank you again, Dr. Cowdery, for going through all of this. This is a heavy topic, and I think you presented it in a way that was very accessible, not overly clinical, and I really appreciate that. So thank you for being here and sharing your expertise with everyone.
Mm-hmm.
All right, so folks who are still on the call, who are still in the webinar, thank you for attending today. This is our third out of 4 days for this overdose series. We encourage you, if you haven't yet, please register for the last day. That is next Wednesday, August 28th. Another plug for that darn survey that I won't shut up about. So fill that out if you want an attendance of or a certificate of attendance today. Thank you. And, just my final little reflections for today. Today happens to be National Fentanyl Prevention and Awareness Day. And, this wasn't fully intentional when we were scheduling things. And we happen to have 3 of our 5 sessions today focused fully on fentanyl, some aspect of fentanyl. And then it came up in our other sessions, at least to some degree. Now, absolutely, fentanyl is extremely concerning for a variety of reasons. And one of our many goals with this series, with the Overdose Awareness series, is to broaden our understanding of overdose and broaden our understanding of the substances involved in overdose. And I think Dr. Cowdery, your presentation especially, really, really addressed that like there is absolutely a concern for over-the-counter medicines as well, along with all these others. And we don't bring that up in a scare tactic-y kind of way, in a way that's trying to cause alarm for everything, but more so that we're all better prepared to have these conversations, better prepared to protect ourselves and our families and our loved ones. Now, folks, the message of safe storage always comes up in Poison Center presentations. I am biased, and it's one of my favorite messages because I think it connects to pick an issue. If we can store it safely, it tends to better outcomes. That whether that's medicine, whether that's chemicals under the sink, whether that's other substances. And my final ask for all of you is please, please, please add the Poison Helpline to your phones right now as you're listening to me talk about it. So 800-222-1222. That is the national number you can call. Any time of day or night, totally free. We're never going to ask you for insurance or billing or anything like that. And for folks who may prefer a language other than English, it's totally fine. We can always pull an interpreter in, still at no cost. And that is a confidential service. So the same rules that protect your info at the doctor's office, at the hospital, apply to Poison Centers as well. You can also call just to ask a question. Say, hey, I heard this interesting thing about acetaminophen today. Might it interact with this supplement I take? You can absolutely ask that kind of question at the Poison Center, at the Poison Helpline. And my colleague Megan King is reminding me that this is the same number throughout the entire US. So it's going to route to your local Poison Center based on your location. All right, now I believe that is it, unless my fellow educators rapidly unmute and yell at me that I forgot some key detail. I'm not seeing them unmute and yell at me, so I think we are good to close this session. Thank you all so much for attending. Stay safe. Reach out as you need. Bye, everyone.